Hi everyone, welcome to another Rafael Medina subspecialty virtual morning report. My name is Hoitin, and today our session will be focusing on Heme on. And we have two amazing clinicians joining us. We have Kim as our case presenter. She is a hematology fellow at Beth Israel Deaconess Medical Center. She finished her internal medical residency at Johns Hopkins Hospital, and her clinical interests include classical hematology. Welcome, Anne. So tell us a little bit about why did you choose heme on, and maybe some word of wisdom for everyone who is interested in hematology oncology.
Sure. So I am really primarily interested in hematology, more classical benign hematology than heme malignancies. And I think it probably started back in medical school. I had some really great mentors who were interested in cancer-associated thrombosis, and I kind of liked the underlying immunology and also the sense of diagnostic reasoning that had to go along with it. Because especially as a general hematologist, you get a lot of cases where like there's some weird laboratory finding and you've got to figure out what's wrong with them. So there's a lot of problem solving that needs to be done. I think my words of wisdom would be the understand how your test works too, and this is true for like coagulation labs too. Like understanding how the PT is done is going to help you understand how to interpret all these labs. So don't forget that labs are not perfect. And so if you understand the laboratory test itself, how it's done, you can kind of understand the results that you get back and put into context.
Yeah, I totally agree with you. Sometimes we send up so many lab tests. It's like, wow, we send up like this is like the whole list, and then we're like, oh, what is this supposed to mean? So, yes, that is a great word of wisdom. So, as our case discussant, we have Dr. Jerry Lee. He is an assistant professor of clinical medicine, and he is a hematology oncology fellow at the University of California, San Francisco. He's actually finished his fellow, and he is stay as a faculty. He is a clinical trialist that specializes in acute leukemia, bone marrow transplantation, histiocytic disorders, and hyperinflammatory conditions. So welcome, Jerry. Thank you so much for being here today as our case discussant. And also tell us why did you choose hematology oncology, and of course some word of wisdom for the future hematologists here in the room.
Sure. Good to meet everybody. I'm not sure if I have any words of wisdom, but I can offer some general thoughts from empiric experience. I love hemonc, and a lot of things that Anne had just said really resonated with me. The combination of diagnostic reasoning, you have to know your labs and why you get them, how it's interpreted. You also need to know a lot of biology, which I love, coming from a fairly basic science type of person and type of background. So I love that marriage between the science that we pursue, either in the lab or clinical sciences, in terms of clinical trials and the patients that we see. I like personally hematology and oncology because sometimes they're incredibly sick, and as you can probably tell from my bio, I really like sick patients. Especially if there's some things we can do about them. So in oncology, there's not necessarily as much, sometimes, unfortunately, we don't have that great of options for solid oncology, but for malignant hematology and certainly classical hematology, there is. And so, I like that about medicine and hematology. Words of wisdom, I'm not sure if I can offer anything, but, I would say if you're passionate about something, then just attack that passion and just kind of follow it. There's not a lot of people who are interested in histiocytic disorders, HLH, VEXA syndrome, all that kind of stuff. So you kind of have to carve out your own niche, and doing that, it can be a bit scary, but also incredibly rewarding and passionate. So that's just kind of life guidance that I would offer.
Thank you. And it's true, it is a very difficult field actually to understand all the different processes. Maybe at the end of the session, we finally understand the coagulation cascade that everybody's so afraid of. So, Anne, if you're ready, and Vinny, if you're ready to show the whiteboard, we can start with the case.
Yeah, so the chief complaint for our patient is that he's 66. He's a 66-year-old male who's coming in with progressive shortness of breath and especially on exertion. So I'll give you a little bit more information with the HPI. He basically developed shortness of breath over the past month, and it's becoming really severe for him, where he's having increasing fatigue. He can't walk his dog and go up hills anymore. And with that, he's noticing worsening chest tightness with the shortness of breath. So he actually got referred for an outpatient stress echo, but he couldn't do it when he got to the laboratory because of the severe dyspnea that he was having, and he's like having some shakiness to him. So they got an EKG for him while he was there. They found him with ST depressions, and then the brief echo that he could have done, they found some wall motion abnormalities and therefore sent him to the emergency room for further workup. The review of systems for him is notable for palpitations, a cough. He had a 10-pound weight loss over the past few months, increasing canker sores of his mouth for the past few years, and then no fevers, chills, night sweats, or bleeding.
Good. Thank you, Anne, for the first algorithm. I know there's a lot of information there. So, Gary, so we have this chief complaint of a 66 years old male with progression shortness of breath. So, shortness of breath is actually a very common chief complaint, but from your perspective, from him perspective, what can you tell us, or what is your first thought about shortness of breath in a patient who's coming in to the clinic?
Okay, so yeah, shortness of breath, super common. Dyspnea on exertion, very common. You all are closer to medicine than I am. So the first step, as we're all internal medicine trained, is to rule out, at least for me, rule out the non-hematologic causes of dyspnea on exertion. So I'm glad that, there was a EKG and an echo that was sent to evaluate cardiac causes, but definitely, also think about pulmonary and, get imaging if needed. And so there's a broad differential here that I'm sure everybody else, again, is more familiar with than I am. As a subspecialist in hematology and oncology, what I typically think about, especially if they're coming to me as a malignant hematologist, is this anemia or not? Are these symptoms related to a cancer or not? And the story is suspicious, right? I mean, we have some, basically hints of evidence that there is some sort of process going on that it may be a malignancy. You've got, some unintentional weight loss, it sounds like, some worsening dyspnea on exertion, some fatigue for sure. And so those would all be consistent in general with cancer and consistent with anemia if he does have that eventually on the labs. The other things I think about is, any sort of risk factors that may predispose a person to developing either a blood abnormality or a solid tumor process. And, is this person a smoker? Are they having worsening dyspnea because, they all have a lung cancer or something like that? Or is there mass effect on any sort of organ, the lungs, and things like that that can cause him to be dyspneic on exertion? So, those are all things I think about as well. Causes of anemia, like then I start thinking about, is there blood loss? Probably not. If this has been going on for a past month, we probably would have led with that. There's some bleeding that he may have had, but you never know. People can have chronic blood losses and not be aware of it at all. Is this person have anemia of inflammation? Is there any sense that this person is, actively inflamed? We might get some more history about that soon. So I think about other things, like fever and, is this person, you mentioned there's no night sweats, which is good. But, I think the whole picture is definitely concerning that there might be an underlying malignancy or anemia that is not well explained right now. So that's kind of what I'm thinking in general. Definitely more as a subspecialist than thinking more broadly about cause of dyspnea on exertion.
And you can move forward with the next aliquot whenever you're ready.
Sure. So, upon talking to him more, his past medical history is notable for hepatic steatosis, essential tremor, and then sciatica. His medications include only vitamin D. Family history has breast cancer in his mother. And then for social history and kind of health-related behaviors, he's currently retired, lives with his partner, no alcohol, no smoking or other tobacco products, and no other substance use. He has no known drug allergies.
Jerry, is this new piece of information with his past medical history and some family history give you more clues about what's going on?
Not really. Family history is one of those things that I think a lot of patients will offer, and they'll say, oh yeah, I had a paternal uncle who died of prostate cancer when he was 80, and what do I make of that as an oncologist? Probably that's just run of the mill. That person just had prostate cancer because they were 80 years old. So the devil's in the details. If this person if the mother of the patient had early onset breast cancer, then that might mean something. So a little bit more detail about the age might be important, but there's not really anything that's screaming out at me so far. If there were several family members that had a history of cancer, especially primary family members, then I would be more concerned if there was an underlying genetic predisposition, but nothing really screams out at me so far. The health-related behavior sounds like it's pretty much benign. It's not an active smoker, no other alcohol or drugs. So overall, that healthy lifestyle decreases risk for developing cancers for sure. So, not much to say there other than, sort of leaning away from kind of the smoking related causes of cancer. And now I'm more concerned about kind of a general workup. I'd be really interested to see what the labs show. As a hematologist, we love labs. We get a bunch of them, and oftentimes those will tell us the diagnosis. So again, overall, this clinical picture does not really push me necessarily one way or the other.
Good. I think that is a very nice piece of information saying like understanding the pertinent negative as well. Like you said, it's not just about having all the answer at first, but now I know that Anne have more information about physical exam and maybe some initial labs for this patient.
Yeah. So just to start with the vitals, he had a normal temperature, normal blood pressure, normal heart rate in like the 70s. Respiratory rate was normal. His SpO2 was also normal on room air. His exam is notable for him looking quite pale. He does not have any cervical, axillary, or inguinal lymphadenopathy, but he does have some mild splenomegaly that's palpated on exam. As far as labs go, he has a white blood cell count of 5.35, a hemoglobin of 2.9, and a platelet count of 180. The MCV is 96. His RDW-SD is 64.1. I will note different places use different ways of reporting this. His ANC is 0.87. I don't have the MDW. The ALC is 3.85, but I can look it up. And his absolute retic count is 0.02. Smear, when looked at, although this is after transfusion, shows hypochromic RBCs with a lot of variation in size. There are no schistocytes, and there's some lymphocytic predominance. Some lymphocytes with some large granules seen. There are no blasts or abnormally large white blood cells seen. For context for the CBC, he had a normal CBC about a year ago, except for mild anemia to about a hemoglobin of 10. His CMP was normal, and then his ferritin came back at 1160 with a T-sat of 94%. His folate was normal, his B12 was normal, his haptoglobin was normal, and then the high sensitivity troponin was 143.
Wow. And there's a lot of lab information that you just gave us. So, Jerry, you were saying that you love lab as a hematologist. So tell us a little bit, how would you interpret this? Because I think most of us just like, oh my God, what should we do now?
Yeah, I'm a little bit that way too. Uh, well, the glaring thing, of course, is the hemoglobin of 2.5. That's I think everybody did a little bit of eyebrow raise when that came up. So certainly this dyspnea on exertion can be explained by that. The other labs are interesting. So the WBC is normal. The ANC you had it at 0.87, is that right?
Mm-hmm.
Okay. So the ANC is low, is not extremely low, but is definitely on the low end for sure. And the platelets are normal. So, I would say this person has a neutropenia plus a severe normocytic anemia, but with a high RDW, implies that there's a high variation the size of these red blood cells. Hard to know what that means right now, just as first blush. What is ARC? Sorry.
Tick count was, let me see, low at 0.02, so like 20,000.
Okay, gotcha. So a low retic can kind of tell you a couple things. It can either tell you that this process has been going on for quite a while, and the body is no longer able to compensate for this worsening anemia, and so basically used up all the nutrients that it takes to make new red blood cells, and thus is no longer able to even make retics. I can also tell you that there's some sort of marrow process that's not allowing retics to be made, either not be able to extrude them from the marrow or a primary marrow process. And, this constellation of findings, the neutropenia plus the severe anemia is definitely concerning for a primary marrow process. The other thing that points to that, of course, is the splenomegaly. Why does this person have splenomegaly? Is there a cancer that's involved, or is this just extramedullary hematopoiesis? The bone marrow is not able to create these new blood cells by itself, so it needs to get the assistance of the spleen to help produce red blood cells as a site of hematopoiesis. So tough to say. I mean, I would probably guess that there's at least some extramedullary hematopoiesis going on in the spleen, but tough to know in this setting. The smear, I'm just taking a look at here. Good that there's no schistocytes, something that we should always look out for in the setting of a person who has anemia. Obviously we're thinking about microangiopathic hemolytic anemia and TTP and all that stuff, but seems unlikely given the clinical scenario. Interesting that there's a lymphocyte predominance. Okay, that explains the overall white count being fine. Although it looks like there's also a lowish ALCs. I mean, I guess that leads me to question, I don't know, Anne, if you have these labs, what is normal on the diff?
Yeah, so his absolute lymphocyte count was actually 3,000, like 3,800. And so for our laboratory, the absolute lymphocyte count normal, the range is going to be 1.2 to 3.7.
Mhm. Got it. Okay. And that's the only, everything else is low.
Mm,
Okay.
Everything else kind of fell. Let me see. Going back to presentation, everything else was normal. His absolute basal count was 0 initially when he arrived, and then varied into a normal range. The
Gotcha.
other ones were normal.
Okay. Gotcha. Okay. Yeah. So the ALC sounds like it's a little bit high. And it being a little bit high could mean that there's obviously some lymphoproliferative process here. but it doesn't necessarily mean it. I'm sure at some point, if we suspect that even more, we'll get some immunophenotyping of the lymphocytes, which can tell us if there's a cancer of the lymphocytes that could be contributing all to the constellation of symptoms. And that also is a good segue because, sometimes lymphomas or CLL and things like that can have paraneoplastic phenomenon that can lead to an anemia. And I'm thinking, should this person need some workup of hemolysis? Because, sometimes you have CLL plus a hemolytic anemia, and that could be explained together pretty nicely. If that were the case, then of course, we would check the haptoglobin, LDH, I'm sure is high, and kind of go from there. But at least from kind of what I have now. Oh, I see the haptoglobin is normal here. Okay. I mean, if the haptoglobin is normal, then that, is less likely perhaps that there's a hemolytic anemia. Haptoglobin is pretty sensitive for that. So that would lead me away to it. Ferritin is high and the TSAT is high. So that is unusual, unless this person, unbeknownst to everybody, had, RBC transfusions right before these labs were taken. This would, to me, imply iron overload. So that kind of raised the question of why does this person have iron overload? Iron overload states, hemochromatosis, thalassemia. It'd be unusual to have a person with this, I think, this degree of anemia from thalassemia without knowing it all his life. And the MCV is also high, or I guess normocytic. And in thalassemia, you obviously have a microcytic anemia, so probably less. So I'm thinking, should this person need some evaluation for hemochromatosis? Not sure, but and did we do the chemistries? Did that look okay?
Yeah, CMP was normal, and then the only other thing was his high sensitivity trope was elevated at 143.
Yeah, great. Yeah, and somebody brought up iron deficiency. Of course, yeah, iron deficiency. So you can have iron deficiency causing anemia, but usually you would see something like a thrombocytosis, which is not here. Your ferritin would be very low instead of very high. So, it's not a clear picture of iron deficiency. You can have different mixed syndromes, but I think with this level of TSAT and ferritin, that is not really on my differential right now.
B12 was also normal at 890. Someone asked in chat.
Yeah, so those are all the thoughts right now. Anything that you want me to comment on?
Yeah, Jerry, actually, I just wanted you to give us a brief explanation how we do the classification between the leukemia, because we are, I mean, for someone who is like an early stage of training, how would you classify that, the leukemia, like with myeloid or lymphoid? How would you approach that?
Sure. Yeah. So in general, there's, obviously myeloid cancers and lymphoid cancers. In the myeloid category, there's your myelodysplastic syndrome, there's the AML, acute myelogenous leukemia, and there's, some other ones. And in the lymphoid category, there's acute lymphoblastic leukemia and a myriad of other ones that can present like a leukemia, such as CLL, chronic lymphocytic leukemia. The thing that I look for primarily is, are they sick or are they not sick? So that leads to me thinking, is this an acute leukemia or not? And, if this person has a hemoglobin of 2.5 and has developed this progressive shortness of breath over last month, it's probably not a super acute drop. This probably been slowly happening over time. So that may lead a little bit more away from an acute leukemia. Acute leukemias obviously will also have blasts in their peripheral blood. And we don't see that, at least on the smear. Sometimes it can be, a little hard to see, but given the fact that it's not screaming out at us that this is an acute leukemia, I'd probably kind of stay away from that for now. And then we, think about kind of the chronic leukemias. There are many. In this case, is this, CLL, acute lymphocytic leukemia? Do I think it's a CML, chronic myeloid leukemia? The differences between the two is that with CLL, you typically have a higher ALC. CLL is on the spectrum, kind of the same disease as SLL, small lymphocytic lymphoma, which is basically just a nodal presentation of CLL. You may not have a super high ALC, peripheral lymphocyte count, but you have enlarged lymph nodes, and it essentially is hiding in there. But CLL and SLL are essentially the same disease. CML, you have proliferation of your myeloid lineage kind of all in general. So you would expect to see, an elevation in your basophils, you see elevation potentially in your eosinophils. You definitely see more of a myeloid skewing, so more neutrophils and all that stuff. And this is not the picture that I'm getting. So I'm not thinking this is a CML for sure. But until we get the bone marrow biopsy for the definitive diagnosis, oftentimes these are a little bit just kind of giving me a clinical gestalt, but not a definitive diagnosis. So that's how I would generally think about this. There, of course, are other leukemias that I talked about before. There's hairy cell leukemia, which can cause pancytopenia. There's something called TLGL, a large granular lymphocyte leukemia, and that could present with pancytopenia, oftentimes with an anemia, oftentimes with neutropenia as well. And the fact that there are some lymphocytic predominant large granule cells on the smear kind of it raises an eyebrow if there's a TLGL in here. TLGL is also very commonly associated with rheumatoid arthritis, and I didn't get that sense here from the past medical history. The typical TLGL patient that I think about is a person who's had, rheumatoid arthritis or some sort of autoimmune disease, rheumatologic disease, for like a decade or 2 decades, and may have been on some sort of immune suppression. And all of a sudden they have worsening cytopenias, and you are concerned about a developing malignancy. You do a bone marrow biopsy and you make that diagnosis. We can talk about it if it gets there, but that is something that is kind of in the back of my mind, but can be a hard diagnosis just to make based on all the peripheral studies.
Wow, an amazing summary. Thank you so much, Jerry, for that. And you can move forward with the case.
Okay, so he does get a bone marrow biopsy given his significant degree of anemia. So the bone marrow flow cytometry results come back with abnormal T cell populations that are positive for CD2, CD3, CD5, it's kind of a dim partial positive. Also for CD7 and 8, CD57 and 16. And then there's monotypia by TRBC1 staining. The actual bone marrow pathology review shows like an infiltrate of like CD5 and 7 positive T cells. And then I'll give you one last piece of information before you ruminate. His myeloid NGS panel came back with a STAT3 mutation, but it's a variant of unknown significance.
Jerry, what about this bone marrow? I think Anne listened to everything you said. Every time you ask something, she's right there. She has the answer for you. So we have so many different markers here. Can you explain to us what does it mean and what is your thought about it?
Well, Anne's a great fellow, so has all the information and can let me ask a question just to clarify. You said CD56 and CD16?
57 and 16.
CD57 and 16. Okay. Interesting. So I don't have the immunophenotype off of my top of my head. Okay. Thanks for whoever posted that CD57 in the chat. The presence of a stat, you said STAT3, right?
Yes.
Yeah, the presence of a STAT3 mutation plus an abnormal T cell immunophenotype definitely raises the specter.
Sorry, I totally wrote a typo. It's 56.
Oh, okay.
That
Got
might help you. That might help you.
yeah. So 56 is an NK marker, and so CD16. So that shifts my thinking a little bit. Okay, so the point is we rely heavily on the immunophenotype from this flow cytometry and the bone marrow biopsy. Okay. And the point is, I, as a hematologist, I don't remember everything, but the basic thing to know, I think that also implies as an internal medicine trainee and above, is that your CD2 through 8 are T cell markers in general. Okay. And CD19, 20, and 22 are your important B cell markers. So the first thing is if you see an abnormal lymphocyte population is to distinguish that if it's just a B cell, abnormal B cell population or abnormal T cell. Here, clearly it's a T cell population that's abnormal.
Gary, I'm so sorry. It
Oh,
was CD56. I'm like triple checking myself on the flow cytometry, but sorry. It was CD57. I'm not crazy.
okay. All right.
I'm so sorry.
So the point with the CD56 versus 57 is that CD56 is a natural killer cell marker. Okay. Natural killer cell lymphomas are quite rare, but they're aggressive types of hematologic malignancies, often associated with EBV, and patients can often be extremely sick. I think a lot about HLH as part of my kind of research practice. And so a lot of these serious NK diseases, lymphoproliferative diseases, can co-present with HLH. And people are really sick. Doesn't sound like it's the case here. Doesn't have fevers, and but it's overall, like, except for the exceptional anemia, is stable appearing. So, given the predominant lymphoid population, plus the STAT3, although it's the VUS, it's hard to know what that is exactly. I mean, I think this is a T cell lymphoma of some sort. I don't know off the top of my head what CD57 is, but somebody in the chat said that it's a large granular lymphocyte leukemia, which, hey, that totally fits. We thought about this before. And if that were the case, that would make a lot of sense with the presentation of STAT3. STAT3 is an important molecule that we think about that is commonly mutated in TLGL. But again, the VUS is hard to know what to really make of that. Yeah, so I probably raise an eyebrow, but may not fully kind of latch on to that right now. But overall, because we do have the finding that this is an abnormal T cell population, I would probably go with a T cell lymphoma of some sort. Question is, did they mention morphologically that there's large granular lymphocytes? Because that's also an important part of the diagnosis here.
So they were seen on the peripheral smear. The bone marrow biopsy also includes large granular lymphocytes.
Okay. So all that is consistent with TLGL.
So, Jerry, if you think about TLGL, can you tell us a little bit more how would you maybe think about a patient who's come in? What are the classical symptoms or some of the lab finding besides the one that we're already seeing here, if that is what you're thinking?
Yeah, if it's TLGL, again, they commonly present with a rheumatologic disease for a number of years. They have large granular lymphocytes that are present in the peripheral smear, also in the bone marrow. They commonly have the STAT3, STAT5, basically JAK-STAT pathway mutations, and it causes cytopenias for sure. The treatment for this is typically immune suppression, usually oral methotrexate given once weekly. There's a possibility that may have some sort of paraneoplastic autoimmune phenomenon too, but predominantly, these are indolent types of diseases, which is also something that we had thought about previously. So that's how I would think about a TLGL. Again, I would have to think a little bit more about this immunophenotype. I'm not a lymphoma TLGL expert by any means, but I would have to rely on our hematopathologist to tell me whether or not this particular immunophenotype would be consistent with that, which I don't have off the top of my head, unfortunately.
Of course. So, Jerry, what are the differential diagnoses that come to your mind that could present similar to TLGL?
So this is clearly a T cell lymphoma type process, or potentially an NK cell type process, as we discussed. But let's kind of stick on the T cell leukemias for now. There's a very heterogeneous group of T cell leukemias, lymphomas. Some of them are extremely aggressive, and some of them can be fairly indolent. And so that kind of spectrum of T cell lymphomas is the other thing that I have on my differential. In a similar category are kind of the NK cell type of leukemias, lymphomas that we talked about, very commonly associated with EBV. They can have, they're usually are more present in Asians from Asia, and often have like a nasal phenotype. So basically, they'll have some sort of nasal mass. Sometimes it could be extranodal, extranasal, but that's less common. So, I didn't get any sense of that. So there's no real reason for me to think of that. But again, those patients are also can be fairly sick and need quite a bit of treatment. I think that would be the predominant thing. Any other hints that Anne can give me?
Any additional labs that would you like to know, Jerry? So maybe Anne has the answer. Ask for it and she will give it.
I see. Interesting. So I'm sure in the marrow that they sent a bunch of different studies. Either do they find any other sort of mutations, or is it just the US and STAT3?
There are some other mutations, but they're pretty non-specific. I can dig them out for you. So for him, he has like EP300, Notch1, B class, Cas-R, PRKDC, but they're all variants of unknown significance. There's no pathogenic mutations noted. Otherwise, the bone marrow path is just more like an infiltrate of cytotoxic T cells. They're all monotypic. His cytogenetics are bland, 46XY. No gene rearrangements of like TP50, of like IGH. There's no mutations TP53. I think that's about it.
Is there any additional imaging that you have?
He did get the CT scan proving that he does have splenomegaly to about 16 centimeters. He never got a CTHF reading for PE, for example, just because by the time we found his anemia of 2.5, we figured it was that causing hypoxic, like cardiac stress, and also the shortness of breath.
Okay. Well, I mean, I think given all that, that's not clearly pointing to one thing, another alternative diagnosis. So I'd probably say that if I were to put my nickel down, this would be a TLGL leukemia.
And you would be correct with the bone marrow biopsy in our pathology report.
Well, thank God.
Oh my God, yes, you were right on about the diagnosis. So yes, Jared, would you like to give us more information or more teaching about this disorder? Anything else that you have not been commented before?
So TLGL, I guess the only thing I would add is with hematologic malignancies in general, you start to think about what is the role of some of the advanced therapies that we have now in this space, right? So not only allogeneic transplant, auto transplant, CAR T cells, bispecifics, all these different things in our toolkit to try to eliminate lymphomas and leukemias. Fortunately, TLGL is a rare disease. It's not a very common type of leukemia in general. And there haven't been a lot of studies looking to advance the therapy for TLGL. The role of an allo transplant is unclear. It sometimes can be used in extremely, extremely refractory cases after people have been put on multiple courses of immune suppression. Like they get rituximab, I don't know, they get some sort of mTOR inhibitor, calcineurin inhibitor, all that stuff doesn't work. They get kind of more big guns like alemtuzumab, which is an anti-CD52 inhibitor, which really depletes. The role of alemtuzumab is to basically destroy all of the T cells in your body, and it commonly does. And sometimes patients will not respond to that. And so in those cases, we may be thinking about an allogeneic transplant, but the evidence for that is extremely limited and really case reportable. So that'll kind of tell you the role of treatment here is really, really immune suppression rather than chemotherapy. There's no CAR Ts, of course, that are approved for this condition, no bispecifics. None of the more advanced therapies have really been advanced here in TLGL. Oftentimes people do respond, but it takes a while. It's not because it's a more indolent type of disease. Treatment can get, you basically start a patient on treatment, and it can take months before their counts get better. So the common thing that I teach fellows is that when you start them on oral methotrexate, or that's typically first line, it can take some time before their blood counts improve, and you should expect that. Don't peel away the methotrexate too early because that would deprive them of a line of therapy unnecessarily. So just kind of expect that things will be slow. This patient obviously is very symptomatic from the anemia and has to be transfused and all that. But hopefully over the course of time with treatment, the TLGL gets better and they can better support their own blood needs. There may be some, splenomegaly is a big part of TLGL too. That's very common. So over the course of time with treatment, I would expect the spleen to shrink as well. So that'd be something that I definitely watch out for. If it doesn't shrink and the cell counts don't get better, then it becomes kind of a tough situation at that point. You switch to second line therapy, which tends not to be that good. People can be on therapy for a long time. So many years, even decades on some sort of immune suppression. You can give them holidays periodically. But they're on some sort of immune suppression commonly for a very long time. Fortunately, because they're older age, it doesn't necessarily dramatically influence their life expectancy, although it does. I'll say just in general, because this is an incurable disease. And people, especially if they kind of blow through first line therapy, they can have really bad outcomes, unfortunately, from pancytopenia, also infections because they're on an immune suppression. So in some ways, this can be a challenging disease to deal with if it doesn't respond.
And I
Got
would
it.
say that he got, I think, 7 units of packed red blood cell transfusions while he was in the hospital. He was discharged on prednisone, like 1 mg per kg, in addition to oral methotrexate at 10 mg per meter squared weekly, so a low dose regimen. And so far, he's been doing pretty well. We actually had to give him 1 unit of blood a few weeks out from his initial admission, but otherwise his reticulocyte count's improving. His hemoglobin's been reasonably stable since his last blood transfusion for the past 2 weeks. So we're hoping he continues to do well on it.
Well, that was my question actually. I was curious about the patient outcome. And so, when you were taking care of this patient, tell us a little bit how was your experience?
I think the questions that we had were kind of centering around we love our laboratory diagnostics. So we're like, well, what's abnormal for him? He's got this profound anemia, maybe some neutropenia, maybe the lymphocyte count is meaningful, and then the splenomegaly, and it's trying to figure out how to piece it together. And I think, as Jerry kind of alluded to, there's so many actual heme malignancies out there. If you were to open up the WHO classification book, there's so many different kinds that it's kind of hard to know without the specific like pathology information which one you're dealing with. You can kind of make guesses, but realistically, you can't diagnose a specific type of lymphoma or like leukemia just from looking at the cells or like even a peripheral smear. So I think part of the learning case for me is just like being patient and waiting for the data to come back. And I think the interesting parts for me were that I don't normally think of TLGL leukemia as having this kind of acute presentation with this severe anemia. What I had read before is that it can happen and progress over time. So I think that was kind of unusual for a lot of the people on the team taking care of him to see him getting diagnosed with this particular leukemia, which is not quite so acute of a presentation usually. And that agreed, he doesn't have that history of the inflammatory disorder or like the autoimmune disorders, which are typically kind of thought to be associated with it. So I think, as many things are true in medicine, you don't always get that classic phenotype.
Did you go searching for, rheumatoid arthritis or less
Yeah,
commonly lupus and all that? And it was completely
yeah, nothing.
no.
And I guess based on what I've read, though, in terms of publications, and there are a couple of people like Thierry Lamy who like to publish a lot on TLGL, and there's a good chunk of LGL leukemia that's not associated with it. I mean, we call it like Felty syndrome for if it is.
Mhm.
Um, but the idea seems to be there is just some kind of immune trigger that gets the T cells proliferating and proliferating, and along the way they develop some kind of activating mutation that allows them to just keep going.
Yeah. I wouldn't say it's the only small thing I would add is, I've definitely seen TLGL without any sort of underlying autoimmune disease, as is this case. Um, and I'm curious, what did you make of the STAT3 VUS? Did you think that that was important?
Yeah. So we thought it's hard to know. So we thought really about what it means because it's not a frameshift mutation. It doesn't just break the protein. That's pretty obvious. It's the insertion of like an extra proline. And I can't tell based on the report if it's at the activating site for the protein function, but it's really hard to know. Like, is that extra proline really going to throw things off so much that it's now hyperactivated? And I think we can't tell. My guess is no, but that SAP3 mutation is so common in TLGL that I feel like we can't discount it. But mechanistically, it doesn't seem to make sense to me. But who can say? We asked our pathology team, and they said, it's really hard to know. They tried looking into any prior published information on this particular mutation, and it's just not coming up with anything.
Yeah. I mean, that really kind of goes to show that there's obviously a lot we don't know about medicine. And there's a lot of biological things that can happen that may be contributing or maybe not. These STAT3 mutations are so common in TLGL, and we expect in this case that it might be contributory, but it's classified as a variant of uncertain significance. So who really knows? Oftentimes, as a hematologist, what I would do is exactly what you do, to kind of look at what is mutated, how the amino acid sequence changes, what domain is it affecting, and do I, based on that information, think that it could possibly be significant. That's obviously something that not an internal medicine resident would do, but just kind of give you a little inside baseball about how hematologists, oncologists will think about it is that way. Would it change management? No. But sometimes it would. Sometimes in other conditions where a genetic defect absolutely needs to be corrected, that would push us towards, for instance, an allogeneic transplant. In this case, not so much, but this is why sometimes this exercise is important. It also assists in diagnosis. So, if all we had was the STAT3 mutation, sometimes I've seen pathologists even kind of call, in a very, non-definitive way for pathologists, a type of malignancy just based on the mutational profiling alone, even if it's like a VUS. So it's a little bit of I've learned throughout the years as a hematologist that pathology is so important, but there's also a lot of subjectivity in there, and there's a lot of unknowns, which is why this is an exciting field.
Yeah, I totally agree. And this is the beauty of mysteries in medicine. Not always the patient present the way we expected in textbook. So Jerry, before we end this session, I would like to ask you to give us maybe the 2 or 3 teaching points from this session.
Yeah, so what I would say is keeping a medicine hat on first, of course, is really important. You don't want to really just fixate on a particular diagnosis just because that's what you're used to. Obviously, it's hard for me as a specialist, and I know this is a heme-related case already because why else would I be here? But keeping in mind all the other diagnoses up front, of course, is number one. Number two is, I found that as a specialist, that once you do gain expertise, the things that become clearer are the things that you know, and then what also becomes clearer are the things that you don't know. So that ability to distinguish, like, when you need help and when is this something in your domain, that becomes a lot better. When you're, I think, in internal medicine, pretty much everything is in your domain. So you're constantly trying to rule out things and go from an extremely large frame of reference into a smaller one. I think as specialists, we have the advantage of starting with a small thing and recognizing when things are not consistent. In rare diseases like this, I'm also aware of what particular illness scripts I have for diseases that I'm very comfortable with, and for diseases that I recognize, but is not really an expert on. So this would be a case of that, right? I see TLGL, but I don't actively seek out those cases. So although I can recognize, if a patient comes in with cytopenias, with or without a predisposing autoimmune disease, has granular lymphocytes in the smear, more commonly has a chronic type of presentation. Maybe there's an acute process that can happen if things accelerate, but again, more commonly chronic. Then I can recognize that there are flavors of TLGL, and can kind of point more towards a differential diagnosis and then diagnostic studies that would lead me ultimately to that diagnosis. But again, I wouldn't be able to do that without the help of our pathology friends. And so, again, us hematologists, we love labs, we love pathology, and those will always help with narrowing it down to the final DX.
Thank you so much, Jerry, for this amazing teaching points. And we learned so much from you today. And It was a great presentation, and thank you so much for bringing the case to us. We have come to the end of the session, and I thank you everybody for joining today, and I will see you next time, and hopefully all of you have a great rest of your day. Bye. See you guys next time.